Welcome to today's discussion on uveitis, which is very important topic. It's about 10% responsible for all the blindness in the United States. So that's a lot. And it's the third leading cause of blindness in developed countries. Highest among the elderly, especially those above 65 years old. They are unfortunately more common in females, and they're more chronic and unilateral, and the most common would be anterior uveitis. So in discussion of red eyes, you need to be able to always factor it. You need to always to be able to factor in, is this uveitis? Now, uveitis is the inflammation of the uvea. Of course, just by the name, you know that it's an inflammation of the uvea. And it could be infectious, it could be traumatic, it could be neoplastic, autoimmune, or idiopathic, meaning we don't know what caused it. It's just there. It's basically an inflammatory response with chemical mediators resulting in vasodilation. So you have very large blood vessel and increased vascular permeability. It's leaking. Those blood vessels are not just large, they're also leaking. And chemotaxis of the inflammatory cells in the eye. As far as classification according to location is, it could either be anterior, meaning in the front part of the eye um, from the uh, iris going forward. It could be in the intermediate part or in the retina or the posterior part, or it could be panuveitis, meaning all. So in duration, it could be acute, it could be chronic, and of the type, it could be granulomatous, it could be non-granulomatous. So you have a lot of different classification, all intended to guide you in how to treat these types of patients. Now, in non-granulomatous uveitis patients, there is no pathogen that we can find, and the patient is responsive to topical treatment. That means when you're looking at it, you don't see any nodules, any granulomas, and that tells you it should be easier to treat. Granulomatous uveitis usually means that there's a pathogen involved. Whether you can find it or not, usually it's inside the granuloma, and because of the granuloma, it's less responsive to topical treatment. Your granuloma is your body's way of defending itself by putting up a wall around the infection or the antigen. Unfortunately, that wall also prevents treatment from going in and resolving the problem. As far as symptoms are concerned, there are redness, there's pain, there's photophobia, there's epiphora, there's blurring of vision, scotomas, and floaters. So the most common and the most obvious would be the redness of the eye. Very similar to this one. And not just the eye, but also the eyelids usually get affected. There's vitiligo. You can see nodules or sometimes lesions on the eyelids. So it's not just the eye, it's also some the areas around the eye that may get infected. In the conjunctiva, what you're looking for is a phenomenon we call the ciliary flush, or what you can also find a diffuse injection. Now, ciliary flush is basically a circumlimbal injection because of the common blood supply with the uveal vessels. So if going back to the previous slide, you will notice that the redness is just a limbal area. It's just on the around the limbus. The rest of the eye is relatively non-congested. If you see a ciliary flush, there are two major diseases that causes this. Number one is uveitis. Number two is glaucoma. when you're looking at the cornea, you're looking at keratic precipitates. It could be granulomatous, it could be non-granulomatous. You could see fibrins, you could see pigments, you can see corneal edema, or band keratopathy. So this picture is basically an example of keratic precipitates. Those are the white spots. Those are not inside, those are not inside floating inside the eye. It's actually on the cornea. It's on the endothelial side or the inner part of your cornea, and they basically look like pieces of tissue paper that was thrown against a glass door. So they could be granulomatous and then or non-granulomatous. You could either see fibrins inside, inside the eye floating. This is a band keratopathy. You notice that the opacity is just in the palpebral area, in the area in between interpalpebral areas. It's in between the upper eyelid and the lower eyelid. It's just that part. That's it's called band keratopathy. And band keratopathy is basically a deposition of the calcium salts in the cornea, and usually happens only after recurrent attacks. And usually the eye is no longer in a very good visual condition. The inflammation causes the iris tissue to become sticky. So you have peripheral anterior synechiae, you have reduced aqueous flow, so your pressure increases, or you have a posterior synechiae, meaning the synechiae is between the iris and the lens, so you'll have a pupillary block, and the pressure will also increase, but more dramatically than an anterior synechiae. The keratic precipitates that you see plastered on the wall, on the cornea, could be, well, are called mutton fat KPs, and sometimes you can also see iris nodules. Those are deposition of macrophages. And if you look inside the anterior chamber, you will see flares, cells, flares, plasmoid floatings, things that are floating inside the eye. So basically cells and flares. We call flare with serous, plasmoid would be fibrinous. That means it's the thicker, it's thicker, more fibrinous, as the name says. And you can see the cells that are floating inside. This is actually a light passing through the anterior chamber. The light beam on the left is the light that is reflected off the front part of the cornea, and the light beam on the right is the light beam that is on the lens, the crystalline lens. So that gray area in between is the anterior chamber with the light passing through, showing you what are floating inside. And what you can see is the cells that are the small white dots, and the flare, meaning those the smoky area. It looks like smoke. When you see smoke and you shine a light through it, you will see something floating in the smoke, not just the smoke itself. You can also see a hypopyon. In this case, it's the white part at the lower end of the iris. You will see that white. It looks like milk inside the eye. It's basically a purulent type. It's called hypopyon. And if there's blood inside, it's called hyphema with hypopyon, which is sanguinoid, basically a mixture of blood and pus. Now, the inflammatory response of the eye to whatever the antigen is or the infection causes a breakdown in the blood aqueous barrier. So you have plasma protein spilling into the anterior chamber. It's floating in the aqueous. That's what we call flare. And we see white blood cells that are floating inside, what we call cells. So the cells and flares is actually the white blood cells and plasma protein in the anterior chamber, and none of them are supposed to be there. The fibrin comes from the clotting factors, and the deposition of the cells and proteins produces KPs and the hypopyon. Okay, so we have the grading, because how do you describe when there are a lot more cells than when your last visit, or how do you describe to the next person or to the person who will check the patient on your follow-up how much flares you got, how much cells you got, so the patient uh, and the following doctor will know whether the symptoms are getting worse or getting better. So a grade 0 would have no flares and no cells. A plus 1 would have a barely detectable flare but 5 to 10 cells in view. A 2 plus, a grade of 2 will have a moderate flare or 10 to 20 cells. A grade 3 would have marked flare and 20 to 50 cells in view, and a grade 4, which is the highest, will have at least 50 cells when you're looking at the patient. So usually you need to count as much cells or create a rough estimate of the number of cells that you're seeing, so you can grade whether the cells and flares are actually significant. Also, looking at the iris, you're looking for the nodules. They have that arrow pointed to at the iris nodule. It's called a Keppe nodule. Keppe nodules are the same iris nodules, but they're at the pupil. And a Busaka nodule would be the same nodule, but they won't be at the pupil area. They would be at the middle of the iris. Well, this one are Busakas, not just the ones at the middle of the iris. The Keppe was the one that we showed you before. The nodules are in the pupillary area. Now, these are posterior synechiae. This one is a synechiae in between the pupil and the between the iris and the lens. So it's attached there, it's sticking there. If you have a 360 degree of this posterior synechiae, it will block the flow of your aqueous and create a closed angle type of glaucoma. You also have atrophy of the pupil, not just of the iris, not just creating more pupils than when they become very severe. So this would also be part of your uveitis. And this is a cyclitic membrane. Now, a cyclitic membrane basically plugs the connection between your anterior chamber and your posterior chamber. And if this persists, pressure will build up and you will go into a full-blown closed angle glaucoma. Now, this is how an angle looks like in uveitis. So if you see nodules, those are called Bellarline nodules. That's what the arrowhead is pointing at. Those round dots, those are nodules. You can also have vascularization, as we described earlier, the pathophysiology of having blood vessels in the angles. You could also have a peripheral anterior synechiae, meaning the iris is being pulled forward compared to a posterior synechiae. The iris is attached posteriorly to the lens. Anterior synechiae is attached anteriorly towards the area of the cornea. Or you may have a secondary ciliary body detachment. So this is how your vascularization is called the rubiosis iridis. You're not supposed to have blood vessels in your iris, but now you see a lot of blood vessels in the iris. These are defective blood vessels. These are abnormal blood vessels, and they keep on leaking, and they're actually going to die off later on and contract, destroying the normal anatomy of your eye. Now, why does this happen? So usually it's because of a lack of normal oxygen supply to the iris. The oxygen supply would have vessel growth factors released, and you'd have new vessel growth on the iris. You'd see this as new vascularization. Since these are new growth, these are leaky vessels. These are abnormal vessels. They're defective, so they're leaking. And if you see a lot of these blood vessels on the iris, we call it rubiosis iridis. And if this new vascular blood vessels find themselves extending all the way to the anterior chamber angle, They may close the angle because these blood vessels, they're abnormal, they leak, and eventually they die off. Unfortunately, they contract. So if they are at the angles and they contract, they actually pull the iris towards the cornea and close off your trabecular meshwork. So you'll now have an increase in pressure in angle closure glaucoma. This is a posterior synechia, meaning the synechia is the iris is actually plastered in forward, such that you can no longer see the trabecular meshwork. It's blocking the access to trabecular meshwork, creating a phenomenon we call closed angle glaucoma. And we need to check the pressure because uveitis usually creates a hypotony, but eventually when the inflammation is severe or the iris has been compromised and pulled forward or pulled backward, you can have secondary glaucoma. So in that case, the pressure will now go up. So you need to monitor the pressure. It may be low at first, but eventually it may go up. In that case, you may also need to treat not just the uveitis, but also the glaucoma. But you need to dig deeper. You need to go inside the eye and check the vitreous. You're looking for cells, flares, and what we call snowball opacities. And if there are not of a lot of snowball opacities, we call it snow banking, and we also see vitreal strands. So snowballs are the smaller ones. The snow bank is actually the white, basically more of like an accumulation of the snowball opacities. Not just at the vitreous, we also see behind the eye, the retina. We could see retinal choroidal inflammatory infiltrates. You have the sheathing of the arteries and veins. Sometimes you will now have retinal detachment or the Schwartz syndrome. You can have the RPE hypertrophy or atrophy, and macular edema or swelling or atrophy of the retina, the choroid, and or the optic disc. Now again, I'll emphasize this again later on, but you need to remember that there are four major complications for uveitis. Number one is cataracts. Number two is glaucoma. Number three, we showed you earlier, the band keratopathy. And number four, cystoid macular edema. So your macula, your macula also starts to become edematous. So let's go with uveitis in terms of course. So if it's less than 6 weeks, it may be acute. It could also be because of recurrency. So again, the magic number is 6 weeks. The less than 6 weeks is acute, more than 6 weeks it's chronic. Chronic uveitis would not look as bad as the acute uveitis. Basically, sometimes they say because it burned itself out, the eye is white. There are mild signs, mild symptoms, very few signs of inflammation, but the damage is still there and may still be ongoing. Now, as far as chronic anterior uveitis is concerned, it may be associated with the following problems. One is arthritis in young people. Usually we see arthritis in the elderly, but juvenile chronic arthritis is actually very, very common in uveitis or commonly producing uveitis. We could also have a posterior uveitis, meaning uveitis in the vitreous or in the retina due to sarcoidosis, toxoplasmosis, syphilis, tuberculosis, herpes zoster, cytomegalovirus, and AIDS. Chronic anterior uveitis may be associated also with Fuchs heterochromic iridocyclitis. It could be asymptomatic, which is about 2% of all the uveitis patients. One of my close friends has Fuchs, and the problem is eventually they have heterochromia, or they have progressive loss of the stromal pigment, and they have mild inflammation that doesn't really respond to medications. Now, this is heterochromia. The normal eye is the darker eye because of the loss of the stromal tissue. The lighter eye, which a lot of people consider the more beautiful eye, is actually the pathologic eye. So in this case, the one on your right is the abnormal eye. As far as the source, it could be endogenous, exogenous, meaning coming from the outside or coming from the inside. In exogenous, it could be because of trauma or because of surgery. Um, as far as inflammatory processes, it could be granulomatous or non-granulomatous, or in 30% of all the cases, we don't really know where it came from. We call it an idiopathic. Now, uveitis could also be segregated into mild, moderate, or severe. Mild uveitis would be have mild, moderate symptoms with vision still very, very good. You could have the ciliary flush, no KPs, and a few flares, about 0 to +1 cells in flares, compared to a moderate and a severe, which will have worse symptoms. Severe would have moderate to severe symptoms. They would have very poor vision. They could have very, very pronounced circumcorneal flush. They will have KPs and they have flares. So not just the difference between all three would not just be the visual acuity, but also the amount of cells and flares. As far as the iris is concerned, because this is an anterior uveitis, mild, moderate, and severe would be differentiated with the degree of the involvement of the pupil or the iris. So mild would have normal pupil, no posterior synechiae, no iris swelling, and the IOP would still be small, would be low. In severe cases, you can have a sluggish or fixed pupil. You can have posterior synechiae. You can have iris crypts, and the intraocular pressure may be increased with moderate to severe anterior vitreous cells. Okay, so how do we manage these cases? So chronic cases need to be referred to an internist if they don't have an internist yet. So basically, you're thinking of systemic problems in chronic cases. In recurrent acute episodes, you can have an urgent referral to an internist or rheumatologist to treat the other problems, special, especially if the problems keeps happening and you really cannot find what's causing the problem. So usually there's a systemic problem that's also triggering this recurrency. In acute episode, it could be or previously undiagnosed acute episode. You need to refer to a hospital or eye department or eye center. Don't try to treat these kinds of patients because they will need immediate treatment. And in all patients, you need to check the intraocular pressure. And you need to tell the patients the possibility of recurrency in their cases. This is not just a red eye that they put an eye drop and then everything goes away and then they're good. This could come back. This could stay for longer, and the more often it comes back, the more it destroys parts of your eye. The treatment is usually corticosteroids, which is designed to reduce inflammation, reduce the leakage, increase the cell wall stability, inhibit lysozyme release by the granulocytes, and inhibit circulation of lymphocytes. So the mainstay of uveitis treatment are steroid drops. sometimes tablets, sometimes injections, but more often than not, these are steroids. We also need to relieve pain by giving them eye drops to create cycloplegia. So not just relief of pain, but we're now preventing the iris from attaching itself to the lens. So we dilate the patient. With cycloplegics, not just a dilator but a cycloplegic, which is different. And the cycloplegia will also stabilize the blood aqueous barrier. We also need to give them systemic steroids, not just eye drops, and NSAIDs to help, as usually aspirin and ibuprofen, to help with the treatment, so you don't have to increase your steroids to a very, very high level. Again, four major complications: cataracts, secondary glaucoma, band keratopathy, cystoid macular edema. Remember these four. These are the four major complications that you're looking for whenever you're dealing with uveitis. You're waiting for cataracts to develop, you're waiting for the pressure to come out, you're waiting for that white um, band keratopathy to appear in front, and you're waiting in case they have cystoid macular edema. So remember that um, uveitis will have easy to spot acute symptoms, but only in acute, and as chronic patients usually don't have a lot of symptoms. And you look for systemic conditions, especially in chronic cases. These conditions may be asymptomatic, but their ESR levels might be very high. They might have inflammatory markers already, even though they don't feel anything. So you need to check those, because if they have asymptomatic problems that are systemic, that might be the cause of your uveitis occurring almost every year or every 6 months. So acute conditions caused by trauma or any injury is very common, but you don't really have recurrency in those cases. And if you have any three recurrent acute episodes that you cannot explain, you need to look for a systemic cause, because that is usually the cause of why you have so much recurrences. And again, as I said, the more recurrences you have, the more problems that uveitis will create, the more damage it will do, and your vision actually deteriorates significantly almost after every attack. So thank you very much. That will be all for today. If you have any comments or questions, don't forget to put them in the comments section, and have a great day. Thank you.